All right, class, we'll continue on with theories of motor control. So we have to be able to explain motor control. So as the theory of motor control, that is a group of abstract ideas about the control of movement. So the definition of the theory is a set of interconnected statements that describe unobservable structures or processes and relate them to each other and to observable events. So really, a theory is something that will help explain motor control. Now, Jules Henry Poincare said, "Science is built up of facts, as a house is built up of stones. But an accumulation of facts is no more a science than a heap of stones is a house." So just because you have a whole bunch of stones doesn't make it a house. Does that make sense? So what we do is we have theories that will put these facts together and help explain motor control. So a theory gives meaning to facts, just as a blueprint provides the structure that transforms the stones into a house. So think of a theory as a blueprint and a guide as to how we can describe motor control. Some of the theories are complicated, some of the theories are simple, and we will learn about a bunch of theories, but we have to understand why we will choose one theory over another. Okay? Now remember that everyone's going to have an opinion. It's kind of like pizza, right? If you ask 10 people, what do you want on your pizza? Some like pepperoni, some like anchovies, some like pineapple, some like Canadian bacon. A lot of people have a definition of what pizza would taste like that's good. Well, same thing with motor control and theories. If you ask a whole bunch of people, they're gonna influence and they're gonna reflect differences in opinion about the relative importance of the various neural components, right? So for example, some theories stress peripheral influences, others may stress central influences, while others may stress the role of information from the environment in controlling behavior. So theories can help explain why we move, how we move. They provide a framework for interpreting behavior. They give us a guide for clinical action. They give us new ideas, but they also will give us working hypotheses for examination and intervention. And there's that quote that I gave you. So we like theories because it will guide us in our practice. Now, one thing to keep in mind with theories is that theories are very dynamic. They're changing to reflect greater knowledge relating to the theory, right? So and then a theory is not directly testable since it's an abstract idea. Rather, theories generate hypotheses which are then testable. Information gained through the hypotheses testing is used to validate or invalidate a theory, right? So remember in biology, it's kind of like you have to make a hypothesis. And then based on that, so let's say you have a flashlight and the flashlight doesn't work. Well, you'll make a hypothesis that, oh, the batteries must be out. So what do? You test it. So you replace the batteries, and if the bulb works, the flashlight works, then your hypothesis was correct. But if you replace the batteries and the flashlight doesn't work, then you have to come up with a new hypothesis and say, oh, maybe the bulb is out, so retest it, right? You can't just assume that just because the flashlight didn't work, it's always the batteries. You have to test it. So these are the theories behind it, right? So you have to make a hypothesis and then test it, and if it works, then that would be true. So hopefully that gives you an example. Now, let's start with one of the theories. It's called the reflex theory, and that's based on Sir Charles Sherrington. So these are the different theories that we'll go through. Remember, these are abstract ideas. So Sir Charles Sherrington is a complex behavior explained through combined action of individual reflexes changed together. Structure of a reflex receptor conductor. So he focused on the reflex theory. Okay, and his research formed the experimental foundation for a classic reflex theory. The basic structure of a reflex is shown right here. And for Sherrington, reflexes were the building blocks of complex behavior. He believed that complex behavior could be explained through the combined action of individual reflexes that were chained together. So Sherrington's view of a reflexive basis for movement persisted unchallenged to many clinicians for over 50 years, and sometimes it's still used to influence thinking about motor control today. So there are always limitations and there's clinical implications. So what I want you to do is I'm just going to introduce this to you. I want you to go into the book and look at the limitations of each theory and clinical implications. And that would help guide you as to which way that you might want to use this theory or not use this theory. But one way that, from a clinical standpoint, how might a reflex theory of motor control be used to interpret a patient's behavior is, in addition to a patient's movement behaviors, would be interpreted in terms of the presence or absence of controlling reflexes. So let's look at some of these baby reflexes. Remember these? Crying, sneezing, rooting, turn towards a stimulus, sucking, calming, swallowing, side stomach sleeping, baby grasping, and the moral of the star reflex. These are all reflexes that a baby has. Right? So a lot of times people will say, oh, my baby's so cute, she loves me, look at her, hold my hand. Sorry, just a reflex. Or just the rooting is if you were to stroke the baby's cheek right here, they're going to turn towards it. Okay, and basically what it is if you were breastfeeding, if you kind of nudge towards it, the baby's going to go towards the stimulus and starts feeding on that. So there are some certain reflexes that will help a child survive, and these sometimes what we can do is if somebody has a brain injury or they have a neurological deficit, we can use some of these reflexes to our advantage. And we'll go over this a little bit more in detail later on, but we can use patients that have had a stroke or certain brain injuries, and we can maybe help stimulate these reflexes to help them perform a task. But these are very interesting, these little baby reflexes. The startle reflex, if you were to go up behind a baby and startle them, their hands go up in the air and they kind of straighten out. So that's interesting, right? If you were to put something into a baby's mouth, they start sucking on it. So even if you put your finger in there, they're going to start sucking on your finger. Okay, so very interesting. These are the reflex theory. Okay. Now the limitations of the reflex theory, they have to be activated by an outside agent, right? Does not explain and predict movement that occurs in the absence of sensory stimulus. Animals can move without sensory. So it doesn't really explain that. Does not explain fast movements, such as a fast typist. Fails to explain single stimulus can result in varying responses. Override stimulus of fire if emergency, right? So if you have a state of emergency, sometimes your brain will override the reflex and override the stimulus. So it doesn't really explain how our body reacts to emergency situations. And does not explain ability to produce novel movements. A violinist can play a cello without practicing cello. So how does that carry over, right? So that's just not reflex. So some of these theories that we're going to talk about, again, these are abstract ideas. There's nothing hard and fast or concrete about them, but it helps explain some kind of movement. Clinical implications, strategies to test reflexes should allow therapists to predict function. Patients' movement behaviors interpreted in terms of presence or absence of controlling reflexes, and enhancing or reducing effects of reflexes during motor tasks. And alternative treatment, we can do constraint-induced therapy, so we can influence the environment that way. And again, we'll talk about more clinical implications later on in the class, but I just want you to understand what the reflex theory is. Now, you have a hierarchical theory, which is a different theory. So many research have contributed to the view that the nervous system is organized into a hierarchy. Among them, Hewlett-Jackins, an English physician, argued that the brain has a higher, middle, and lower levels of control, equated with higher association areas. So we have this organizational control from top down. Boom, 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 boom. Each successively higher level exerts control over the level below it. When you have a vertical hierarchy, lines of control do not cross. They never bottom up. You don't go from the bottom up. So each theory has limitations. So what are the limitations of the hierarchical theory? Cannot explain dominance of reflex behavior in certain situations in normal adults. For example, stepping on a pin results in an immediate withdrawal of the leg. This is an example of a reflex within the lowest level of the hierarchy dominating motor function. It is an example of a bottom-up control. So it doesn't really explain, how it has a limitation, so it overrides that control. Thus, one must be cautious about assumptions that all lower-level behaviors are primitive, immature, and non-adaptive, while all higher-level cortical behaviors are mature, adaptive, and appropriate. So this theory has its own limitations, but some clinical explanations explain disorder motor control in patients with neurological disorders. So Bobath, Brunstrom, they use this for control, especially with kids with cerebral palsy. And again, I'll give you more examples of this later on, but Bobath is a whole new system that uses the hierarchical theory to treat kids with cerebral palsy, Down syndrome, you name it, and they use this hierarchical theory. So each part of rehab will take certain aspects of a theory and apply it. And again, in the beginning, this is all overwhelming, but the more you hear it and the more you study it, you'll be able to understand it. And remember, the key is there's not one theory that I use in the clinic, and there's not one theory that you should always. You should use a combination of theories, more tools on your belt. But the more you understand it, the better off you're going to be. All right. So if you look at this structure here, now I'm not going back to anatomy, and I'm not going to go back to your basics of motor control. So this is should all be review for you. So, but if you look at the cortex, the brain cortex, what does it do? Well, it helps do equilibrium reactions. Then it does bipedal function. The midbrain does writing reactions. It can help with quadrupedal function. And then if you have brainstem and the spinal cord, it does a primitive reflex and apedal function. So depending on where the lesion, the brain injury is, if you have injuries at the cortex, if you have injuries at the midbrain, if you have injuries at the brainstem, you can see what kind of effect it will have on the individual and what are some things that we might have to work on, right? Or some of the things that they might have problems with. And we'll discuss this throughout the whole semester, but as you do your case studies, see what part of the brain is injured, or if they have neurological issues, and what are some things that they're going to be able to have issues with. Now, here's another theory. It's called the motor programming theory. So if a motor response is removed from its stimulus, it's left with concept of central motor patterns. The central motor patterns is motor program, more flexible than concept of a reflex activated by sensory stimuli or central processes. So this is motor programming theory. What are the limitations of this theory? Cannot be considered a sole determinant of action. What are some clinical implications of this? Well, it allows the clinician to move beyond reflex explanation for disordered motor control. Retraining movements important to functional tasks, not just on re-educating specific muscles in isolation. So this one, we like the motor programming theory. This will help patients with cerebral palsy, with strokes. We're reprogramming the brain, right? It's not just based on reflexes alone, because reflexes just give you the same reflex. Right? It's the same kind of behavior. The motor programming will allow us a little bit more flexibility. The beauty of motor programming theories is that they basically moved away from views that the central nervous system is mostly a reactive system, right? Instead of reacting, and have begun to explore the physiology of actions rather than the physiology of reaction. So we always react to something, but then this is taking it one step further. So reflex theories have been useful in explaining certain stereotype patterns, right? Boom, boom, boom. However, an alternative way to review reflexes is to consider that one can remove the stimulus or the afferent input and still have a pattern motor response. So I know it gets a little complicated, but if we remove the motor response from its stimulus, we are left with the concept of a central motor pattern. And this concept of a central motor pattern or motor program is more flexible than the concept of a reflex because it can be activated either by sensory or central process. So it gives us a little bit more flexibility in our ability to work with patients instead of the same pattern. Remember, society itself is reactive. We always react to something. But this is planning ahead and saying being able to go beyond that same reaction that we have. Now, we have system theories. You have this gentleman named Bernstein says you cannot understand neural control of movement without understanding of system you're moving and external and internal forces acting on the body. have to understand the coordination of movement, process of mastering redundant degrees of freedom and moving organisms. So in the systems theory, Nikolai Bernstein, who was a Russian scientist, was looking at the nervous system and the body in a whole new way. Previously, neurophysiologists had focused primarily on neural control aspects of movement, but Bernstein also participated in the development of motor program theories, recognized that you cannot understand neural control of movement without an understanding of the characteristics of the system you are moving and the external and internal forces acting on the body. So he would describe the characteristics and looked at the whole body as a mechanical system with mass, subject to both external forces, so more physics-based. Right? He does show that the same central command could result in quite different movements because of the interplay between external forces and variations in initial conditions. So now you're manipulating the environment, manipulating the external forces, and say, well, we can get a different response if we change that. It's the same thing that, like, let's say you go to the gym and you're doing a 5-pound bicep curl versus a 30-pound bicep curl. Well, you might change the behavior because you change the external forces on that, which makes sense, right? So all these things you understand. I mean, you do it all the time, but these are the theories that are showing you why we do certain things and explaining that, right? We do progressive overload. So if you know that theory in weight training, progressive overload, but this is a theory to explain that progressive overload, right? We always do certain things, but now we understand the concept behind it. So continuing with the systems theory, it relies on the principle of self-organization. When a system of individual parts comes together, elements behave collectively in an ordered way. So the take-home message with the system theory is really he basically has less emphasis on the neurological system as a whole. Right? So a lot of times these theories will base it on the neurological system, but what Bernstein says is that we don't want to rely just on the neurological system. There's a lot of things at play, different theories and different systems at play. So this reminds us that the nervous system in isolation will not allow the prediction of movement. However, a limitation of some variations of this model can be presumptive that the nervous system has a less important role in determining the animal's behavior, and that is the key concept here. Okay, and it's a dynamic theory. New movement emerges because of a critical change in one of the systems, controls the parameter, and a control parameter is variable that regulates change in behavior of the entire system. So this is probably one of the most complex of the theories, and one thing that you would probably want to read in chapter 1, because it really gives good clinical examples, and you want to read more about it. But it gives us variability, not considered a result of error, but as necessary condition of optimal function. Small amount of variability indicates highly stable behavior. Attractor states, highly stable, preferred patterns of movement. So these are just different ways that we can manipulate the environment, manipulate the patient, and it will change their behavior. So what are the limitations? It presumes that nervous system is less important role in determining animals' behavior. So when all these other theories say, hey, the neurological system is the key, it's the central nervous system, this theory says, well, you know what, the neurological system or the nervous system isn't the only system that's important. You've got other musculoskeletal, you've got other factors that are important. That's why this theory is a little bit complicated. It says there's synergies and there's whole systems that need to be at play. And I agree to this. We can't just solely focus on a neurological issue, right, or the neurological system. We have to look at other theories, and we have to have, again, that's why I don't use just one tool. We want to be open to a whole bunch of other ways. Clinical implications stresses understanding body as a mechanical system, movement is emergent property, and retraining movement in patients with neural pathology. So we have to retrain the body using synergies. We have to retrain the body using musculoskeletal systems, being variable. It doesn't have to be non-linear, right? So there's a lot of variabilities. And again, we'll talk about these theories in clinical aspect a little bit later, just understanding this system theory right now. Now the last theory is the ecological theory. Motor control evolved so animals could cope with the environment around them. Broaden understanding of the nervous system. Again, that goes back to the the basis of the nervous system, where the systems theory didn't focus on the neurological, but the ecological theory understands, goes back to the nervous system. Perception action system actively explores the environment to satisfy its own goal. So in the 60s, James Gibson was beginning to explore the way in which the motor system allows us to interact most effectively with the environment in order to become goal-oriented, right? So we have a goal, and then how do we achieve that goal? So before we go into the limitations, so an example of this ecological theory is, let's say a child learns to grasp, or reach and hold something, right? Well, just because he learned that ability to reach and hold something doesn't mean that he's going to grasp and hold everything that he sees, right? He's going to determine what do we need to grasp, what do we need to reach for, and being able to understand what he grasps and what he doesn't is the ecological theory. And that makes perfect sense, right? We don't go around reaching for everything or grabbing everything that we see. We survey the environment. We see that just because we have the ability to do it doesn't mean that we have to do it. We have to have a purpose for it. So that ecological theory. But the limitation of that, research emphasis shifted from nervous system to the organism and the environment. So instead of relying on the nervous system, now the organism makes these decisions, and the environment will influence that. And yes, that is important, and it's a good theory, but clinical implication describing individual as an active explorer of the environment. So he's just always exploring. I like this theory. It's a good theory. We always should be actively exploring the environment. All right. So although the ecological approach has expanded our knowledge significantly with regard to the interaction of the organ and environment, it's intended to give less emphasis to the organization and function of the nervous system. Again, so thus the research emphasis shifted from the nervous system to the organism itself. So based on all these theories, right, you're like, all right, Patel, you gave me all these theories, ecological theory, systems theory. Well, which one's the best? Well, there's no one theory that has it all. Best theory of motor control, one that combines the elements from all theories presented. So that's why I said having a whole set of tools and being able to manipulate and saying what's the best for my patient at this time is the best thing. Just like in orthopedics or even working out, you have tons of ways of doing a bench press, doing a bicep curl. But picking which exercise is appropriate at the right time, whether you're going to do free weights, whether you're going to do a kettlebell, whether you're going to do something functional, that's something that you decide. And so based on your patient, you're going to decide which theory. And again, these are just abstract ideas, which one you're going to do. You can do a systems approach. Movement emerges from interaction between the individual, task, and environment. So you have to take everything into consideration. What's the individual I'm working with? Is it a child? Is it an adult? Is it someone that's elderly? What's the task I'm trying to do? Am I just trying to walk? Am I trying to run? Am I trying to reach for an object? And what's the environment? Am I in the house? Am I outside? Is it raining? Am I playing sports? So you have to take all that into consideration and decide which theory you want to apply. So the scientific theory provides a framework that allows integration of practical ideas into coherent philosophy for intervention, and the clinical practice evolves in parallel with scientific theory as clinicians assimilate changes in scientific theory and apply them to practice. Okay. In neurological rehab, reflex-based neurofacilitation approaches. So neurofacilitation, retraining motor control through techniques designed to facilitate and or inhibit different movement patterns. So we want to turn on certain things and turn off different things. Right, so if you have a flexion bias, we want to be able to, let's say you have a contracture where your biceps, where your forearm and your elbow is flexed. We want to find ways to facilitate. Basically, we want to find ways to turn on the triceps and turn off the biceps. Okay, so those are some things that we want to do. So maybe just having the patient reach for something, we have to use the triceps to reach, and that will relax the biceps. So using reciprocal inhibition. So there's a lot of techniques that we'll teach you throughout the semester. Facilitation is intervention techniques that increase patients' ability to move in ways judged to be appropriate by the clinician. Now, the task-oriented approach. This is probably the most important approach that we like to use here. And the normal movement interaction among many different systems, each contributing different aspects of control. Movement organized around behavior, goal, and constrained by the environment. So what is the task at hand? What's the environment that we're doing? And that's the task-oriented approach. So each approach is based on the task that you want to accomplish. Do you want them to reach? Do you want them to walk? Do you want them to sit? So the task-oriented approach is one approach that I probably use the most in the clinic. And so this is something that I want you to emphasize, and I want you to, you don't have to do what I do, but it seems to work the best. One of the newer approaches, it's one of the newer approaches to retraining in the task-oriented approaches and in clinics. It also helps abnormal motor control. Movement problems result from impairments within one or more of systems controlling, and then adaptation to changes in environment, context, critical part of the recovery. So underlying assumptions that you make during the task-oriented approach is that normal movement interaction among different systems, each contributing aspects of control. Movement is organized around behavioral goal and constrained by the environment, and movement problems from impairments within one or more systems controlling the movement. Okay, so those are some assumptions that you make. The clinical applications of the task-oriented approach is when retraining movement, essential to work on identifiable functional tasks. Assumes patients learn by actively attempting to solve problems inherent to a functional task. So you don't spill it out for them, you let them work through these problems as well. You actively attempt to solve the problems in that function. So this is a great approach, and you don't realize that you're probably using this approach, but now you'll know. Once you understand what a task-oriented approach is, you'll be able to say, okay, that's the approach that I use. So you tell a patient, okay, the task I want you to do is reach for this object. Okay, so basically based on the individual, based on the motor control, based on the environment, they're going to use a task-oriented approach to accomplish the task.